Okay, good morning or afternoon or evening, whenever you're looking at this prenatal antepartum nursing assessment. This is Judy Hervey, and this is for 406 Reproductive Health. So here we go. We're going to talk about antepartum care, or sometimes you'll hear it referred to as prenatal. They basically are one and the same, and there are your objectives. So basically, you hear me and you heard me all during patho to stress healthy behaviors. And we need to be practicing this anyway, simply because sometimes you never know, especially if you're a woman, young woman, and looking to have a child, because we never know when we are going to get pregnant. And this includes any over-the-counter medications, supplements, and prescriptive medications that would be from a prescription, unless an obstetrician says it's okay. Because even, high levels of ibuprofen can help a woman bleed, and we don't want them to bleed when they're pregnant. Alcohol and tobacco are contraindicated. They've gone back and forth with alcohol and the, amount of alcohol that we can actually have. And we actually have a syndrome called fetal alcohol syndrome, and they do not know how many drinks it takes to have that. But severe birth defects with that syndrome. Tobacco, a lot of times, are low birth weight, and it's because we know the ENs will constrict. So it causes constriction of oxygen-saturated blood to the fetus. And the last point is pretty obvious. So what is the purpose of prenatal care? What is it? Basically, it's to identify existing risk factors and other deviations from what we call normal. And sometimes if we can identify it, we can do something about it to actually make it better or be ready for it when the baby is delivered. An emphasis on prenatal care is going to be preventive and optimal self-care, that we actually need to teach people how to care for themselves while they are pregnant. Certain things they can and can't do or just go against advisement. Prenatal care is sought routinely by women of middle or high socioeconomic status, which is another problem. It's why are our lower socioeconomic people not seeking care, or is it access? Do they just not have access? Something to think about. So nursing assessment in prenatal care is extremely intense. Every single one of these bullet points is big and expansive. So we're just going to touch on a couple points here. And then as the cases come up, we can identify the different factions within them. But obviously for a history, a reproductive history, if there is one, if not, they may just want to know if, how many kids grandma or mom had, and if there was any problems with any type of reproductive organ with any of the women in the pregnant person's life. Obstetrical history, contraceptive use, gynecological diagnosis, definitely looking for any STDs on board, which can cause scarring. Medical history, including the woman's immune status, extremely important. You contract rubella during pregnancy, high rate of miscarriage, and it can definitely cause anomalies in the fetus. Hepatitis B, out of all the hepatitis, this is the one for the maternal to child one that is the worst. Family, any genetic disorders that are specifically looking for heart and respiratory problems, current medications, and including substance abuse. And so what we need to do here is we have to have a very non-judgmental attitude, especially if we think that they are using, but yet here they are in for prenatal care, which, by the way, is fairly rare. If they're using, they usually stay away from this whole process. But, I'm saying that in judgment. That's just what my experience has been. But maybe they are in denial and they don't think what they're doing is that bad. So basically, we have to have a non-judgmental attitude when interviewing the client regarding substance abuse. And, we can look at, do they have a lack of grooming? Do they have marks on their arms? But what I have learned, if you basically say to them, we're trying to figure out how to help you treat the baby a little bit better, or help you figure out a way to where we can not sustain this behavior so that the baby can grow normally. When you do that, most of them will try to comply with you. I don't think anybody, drug addicted or not, wants to have a child with a problem. That's not what the goal of most people are. And then teratogens. What is a teratogen? What is it? If you were sitting in front of me, I would be waiting for an answer. So anyway, it's any substance that can cause defects in the developing embryo and fetus. Any substance that can cause defects in the developing embryo and fetus. And so here's examples of teratogens right in here. FDA pregnancy category X drugs, any radiation. That's why, nurse working in the hospital, they always put, iron or very, very thick aprons on us if we were assisting them taking, an x-ray of a person. Alcohol, cocaine, moderate to heavy caffeine consumption, although that's being looked at, that's not actually been proven. And then maternal diabetes, methamphetamine use, anything that is out of the ordinary. So let's look at the FDA pregnancy categories as far as looking at that category X drug. Category A is adequate and well-controlled substances have failed to demonstrate a risk to the fetus in the first trimester of pregnancy, and there's no evidence of risk in later trimesters. So if it's a category A, it's an okay drug, basically, is what they're saying. It hasn't demonstrated to show any problem to the fetus. Category B is in animal reproduction studies have failed to demonstrate a risk to the fetus, and there are no adequate and well-controlled studies in pregnant women. So that's category B. It doesn't mean it can't hurt the person because it hasn't been studied in a person, only animals. Category C is animal reproduction studies have shown an adverse effect on the fetus, and there are no adequate and well-controlled studies in humans. But potential benefits may warrant the use of the drug in pregnant women despite the potential risks. That's C. Category D is there's positive evidence of human fetal risk based on adverse reaction data from investigational or marketing experience or studies in humans. So category D, category X, we are not absolutely going to use. I don't even know if I'd use C. But again, I'm going to say D again. It's a positive evidence of human risk based on adverse reaction data from investigational or marketing experience or studies in human beings. But potential benefits may warrant the use of the drug in pregnant women despite potential risks. And then category X is the one that studies in animals or humans have demonstrated fetal abnormalities, and there is positive evidence of human fetal risk based on adverse reaction data from investigational or marketing experience, and the risks involved in use of the drug in pregnant women clearly outweigh the potential benefits. Those would be, again, probably alcohol, cocaine, methamphetamines, heroin, all of those would be category X. Okay, those are our categories of teratogens. Then we're going to talk about gestational diabetes because it is so common. It basically complicates 4% of all pregnancies in the United States. The risk assessment for GDM, which you're going to see a lot of for gestational diabetes mellitus, so it's the sugar diabetes down here, GDM is the abbreviation for that. Risk assessment for GDM should be done in the first prenatal visit. And as you can see here, I've divided it up into low risk and high risk criteria. If you're younger than 25 years, but then, most of the people your generation are having kids over 30. Weight normal before pregnancy, and we know that diabetes is associated with people being a little bit too big. No known diabetes mellitus in first-line degree relatives, no history of abnormal glucose tolerance tests, no history of poor obstetrical outcome, an ethnic group with a low prevalence of diabetes mellitus. High-risk criteria and severe obesity. And folks, you guys, that's only 20 pounds overweight. That's obesity. Prior GDM or delivery of an LGA baby. LGA means large for gestational age. And one of the reasons they're large is for all the free-floating sugar. Glucosuria, what does that mean? That's glucose in the urine. And the family history of diabetes mellitus type 2, because it would not be type 1 for sure. We know the ethnic group with a higher prevalence would be our Hispanics in this area, very, very Indians, more common in this area would be our Hispanics. That doesn't mean you can be Caucasian and not have a high prevalence to it, especially if I've got so many family members that are borderline pre-diabetes or diabetics. So definitely runs in different family lines. Okay. Assessment. Originally, they're going to do an interview. They're going to do a physical exam. And they're going to do a fetal assessment. And we're going to be looking at the fundal height. And what is the fundal height? What does that mean? That's the top of the uterus. They measure that because when you come in the next time, if it's extremely much higher, they may think there's more than one baby in there. So they'll do the gestational age through our estimated date of birth, which I don't know if we've done yet. If we do, you guys know what I'm talking about. Our EDC, extra expected date of confinement, which is basically the due date. And I think we will go over that during this PowerPoint. Okay, so first trimester, what are we looking at in the first trimester? Physical and psychosocial changes, common discomforts of pregnancy, measures to provide relief, lifestyle. We want them to keep exercising, except like you can't ride a horse. There's certain things, probably shouldn't be on a skateboard or a scooter. Nutrition, sex, dental care. Bacteria can definitely get in the bloodstream through our gums, so definitely take care of your teeth. Over-the-counter and prescription medications, again, nothing unless the doctor says it's okay. Tobacco, alcohol, substance abuse, all of that needs to go away. And then STDs obviously have to be medicated for at this point. Possible complications, choosing an OB, fetal growth and development, we're going to be teaching them about that. Expected laboratory testing, and then again, there's the estimated date of birth using Nagel's rule, which I will do on the next video. Okay, I'll be back soon.